morning, everyone. My name is Sham, and I'm one of the Pediatric Emergency Medicine Fellows over at Dell Children's. And today we're going to talk about concussion and why we really don't like that word anymore. And I'm going to teach you a new word to use. We're going to talk a little bit about the words concussion, minor head injury, mild traumatic brain injury, and then we're going to talk a little bit about the whole spectrum of concussion. There's going to be a little bit of information that might be superfluous if you're an EMS provider, but I'm glad that there's nurses here too, so we can talk a little bit about how we think about concussion and head injury in the hospital and the pre-hospital setting. So hopefully we're going to touch on a little bit of information for everyone. I'll try to make this as short and sweet as possible, and then I know we'll have a panel discussion later, and you can save your questions for that point. Okay, so just a quick by the numbers. We've seen the number of head injuries that we are evaluating in the hospital setting just rising. So in 2007, there were 461,000 cases of any sort of head injury that were evaluated in some sort of hospital setting in this country. And this was for kiddos 14 years and younger. And then in 2013, that number is 642,000. So the number keeps going up and up and up. And one of the reasons for that is the fact that the media has so highly touted concussions and the repercussions concussions have as kids get older, especially with football injuries. We hear a lot about that. Speaking of football, can anyone guess what sport has the most number of concussions? Soccer. Okay. Do you know specifically boys or girls? Soccer. Okay. Do you know girls soccer? That's right. So girls soccer has statistically the most number of concussions. Just keep that in mind. I know at Dell Children's we see a lot of male football players come in with these injuries, but man, it's the girls that tend to not want to tell their coaches that they're having these issues and problems down the line. So just be careful with girls soccer injuries. So the cost of concussions has also been crazy. This is a quoted cost from 2012, and I'm sure that cost has now gone up since we're seeing more and more of these injuries, but it was $1 billion annually. And there was this interesting study that I just wanted to put out there, since I'm speaking to some EMS providers here today. This was a study done in El Paso, so it's from Texas, and it looked and compared how well EMS providers are at recognizing pediatric concussions. And they had about 56 people participate, and 38 EMS providers and 18 nurses and doctors participate. And they wanted to see whether there was any sort of statistical difference between whether nurses and doctors can identify concussions versus EMS providers. And guess what? You guys are just as good as all the nurses and doctors, so everyone's on the same page. And this was despite of age, gender of the provider, how many years they've been in practice, whether or not they're a doctor, a nurse, or an EMS provider. So everyone, or the last one is how many concussions they've even taken care of. So everyone is really good at identifying concussions. So I think I can stop my talk there, right? You guys are all good, okay? So concussion is the big word that's been thrown around and used a lot, and really, most of my talk is based off of a new report that was published by the CDC back in the fall of 2018. And this huge commission is a conglomeration between the American Academy of Pediatrics and the American Association of Neurologists. They came together and they came up with this consortium. It's known as Heads Up. And these are new guidelines and new recommendations by the CDC that were just published in the fall. And they want us to stop using the word concussion. They want us to start using the word mild traumatic brain injury instead, okay? And that is going to take a little bit of time to change that because lay people's understanding and the media's use of the word concussion, it's going to be a change. It's going to take some time before that change happens. For the purpose of this talk, I'm still going to be referring to it as concussion, okay? So I'm still at fault because I still use that word as well. But just for you guys to be aware, they want us to start using the word mild traumatic brain injury instead. So a concussion occurs when there's any sort of force applied to the head or the body. It's known as a bump, a jolt, anything like that. So it's interesting because we have always been traditionally taught that a concussion can happen only with head injury. But I want you to kind of take that back and say, hey, concussion can happen with any sort of injury to the body, okay? And a mild traumatic brain injury refers to brain injury with no clinical significance or clinical consequences. That means there were no interventions performed, there's nothing going on. And a CTBI is the word that refers to a clinically important traumatic brain injury. And these are those cases with any sort of neurosurgical intervention, need to stay in the hospital, some sort of finding on imaging, okay? And concussions cannot be diagnosed with an MRI or a CT scan, okay? That's why this is one of those rare diagnoses where we get to use our clinical acumen. It's all based off of symptoms, okay? And we're gonna talk about those symptoms. Does anyone have any idea why kids are more susceptible to head injury? There's more head, exactly, okay? So proportionally larger heads in kids, okay? So they are going to be more susceptible to injuries. Any other structural, physical reasons that anyone can think of? Okay, so they have a thinner skull, thinner cranium, okay? So that's one. And their brain tissue is a little bit more softer and pliable, okay? So they're still developing, their brains are still developing, and because they have that little extra cushion, any sort of force or jolt to the head is going to cause them to have a little bit more oomph to it. And because their heads are proportionally larger to the rest of their bodies, they also have more blood flow to the head. So that's also thought to be there. Those are all the kind of structural reasons. There's a few other neurochemical reasons. Okay, so you guys get called to a scene, and a kid has had a head injury. What are the types of questions that you guys are asking? Loss of consciousness, perfect. Anything else? Okay, whether they're acting appropriately. Seizure activity, excellent. Yeah, absolutely. Okay, so when we're talking about the injury itself, these are some of the big things that we want to really hit, okay? And for us in the hospital, the nurses, the doctors, this is what we want to hear, okay, when EMS providers come to us with a patient like this. We want to have a good description of the event if anyone saw what was happening, right? We want to know what type of force, whether they were wearing any protective equipment, where exactly was that force in their head or anywhere else on their body, okay? And then we want to know about amnesia, both retrograde and anterograde, right? So what is the last thing you remember before this happened? Or what is the first thing you remember after this happened? Loss of consciousness. If there were witnesses, we really want to have them kind of corroborate their stories, right? Yes, he was hit this way. Well, no, he's telling you all these things about crazy stuff, and he doesn't live there, he doesn't go to school there, I don't know what he's talking about. And then seizures, right? This seizure-like activity has an interesting kind of spectrum, because when we first see head injuries, we can see kind of like an initial convulsion with that force, right? And that is pretty normal, and that freaks parents out when they have a head injury and then they start having a few twitches, but that's completely normal. It's the prolonged seizures or the subsequent seizures that do really worry us with any sort of head injury, okay? A little bit more about the neurochemical reasons why children are more susceptible. We talked a little bit about the anatomic reasons, but their neurons aren't as well myelinated as well. That also predisposes them to having worse sort of sequelae from head injury, and then they're just more susceptible to these metabolic and chemical changes. Let me make sure I haven't forgotten anything. Okay. And then the big thing is making the diagnosis of a concussion, okay? What are some of the things that we think of when we hear the word concussion or mild traumatic brain injury? Repeated questioning, okay? Yeah, mechanistically, but what symptoms are we looking for? Unequal pupils. Well, unequal pupils would tell me that there's more than a concussion going on. Drowsiness, great. Vomiting, yeah. Okay. So when we think about concussion, there's a few symptoms that we see kind of early on in the course of concussion, And then there's these danger signs, and this is probably where we're going to spend a lot of our time talking about when we need to get worried about any sort of head injury and whether these patients need to be transported to a hospital. There's a lot of times when parents or coaches or teachers or whoever that you're there are going to say, you know what, we're good, we'll watch for these things. And so this is kind of the information you want to tell them. You know, if any of these things happen, keep an eye out. And then at the same time, there are people that are like, oh my gosh, you know, we got to get our kid to the hospital right away. And, you know, sometimes they just slipped and fell on the ground and, you know, onto like fluffy carpet. And you're like, you know what, you're going to be just fine. So we've got to really kind of think about the mechanism and then think about the symptoms they're having. Like I talked about, any sort of head injury can have concussion type symptoms, okay? What predisposes kiddos to have worsening concussion symptoms are any sort of prior head injuries. And we're going to talk about a few scoring tools that exist and what you can find online and what the CDC really has in various settings. But the real big early signs are that dazed, kind of, you know, like unclear what's going on. They're confused a little bit about what's happening right now. They're having repetitive questionings. They're very slowed in their actions and in their words. And they have some degree of amnesia, either retrograde or anterograde, okay? So these are kind of the big ones that we really think about when we think about concussion, okay? In the immediate setting, there are other symptoms of concussion, which we'll see in the scoring guidelines, that can happen later on out, but something that you're not going to identify right away. And these are the emotional symptoms and kind of the sleep issue symptoms that we see with concussion. The danger signs, as someone mentioned earlier, pupil asymmetry, right? If their pupils are unequal, we got to think about what's going on up here. That's more than just that jolt, okay, that's causing some symptoms of concussion. If they're getting progressively more sleepy, we need to worry about that. You know, you cannot keep them awake for the life of you. Their headache is getting worse. They're having, you know, some weakness, numbness, or they're just walking funny. Their coordination is off, okay? In those settings with weakness and numbness, we also have to think about whether there's potential for cervical spine injury. I'm not going to cover that today, but especially with those symptoms and the mechanism, you know, you guys have your own protocols out in the field on when you need to apply C-collars, et cetera. You keep doing that, okay? Repeated vomiting, right? 1 or 2 episodes of vomiting, you know, it could just be a concussion. It could just be that injury. But if they're retching and they're continuously, you know, vomiting, then we got to worry about it. Slurred speech, convulsions that are more than just that initial trauma, and then really hard time recognizing people in places they should normally know, okay? And then agitation. This is actually the thing that's really scary, and you see and you're like, man, this person definitely has a bad head injury. Is they're normal, they're fine, and then they start getting confused, and then they go on to becoming more and more agitated. It's that agitation that really worries us and probably tells us there's something going on. And this kind of plays into that unusual behavior aspect of it. And then the loss of consciousness. This is kind of interesting just because there might be some initial loss of consciousness, but with any sort of loss of consciousness, we should really think about getting these patients to be seen by a medical provider and getting some care done or having a closer eye on them. And the reason for that is, has anyone heard of the lucid interval with the epidural hematoma? That's exactly the reason why, okay? So we want to make sure that we're not missing anything like that, okay? Does anyone have any questions about this? About our diagnosing? Okay. So we do have a few tools at our disposal. I know when you're out, you know, on a scene call or something like that, there's no way you can go to the CDC website and kind of pull out a form and, you know, let's make sure they're meeting all these criteria and questions. You guys have to make your decisions in real time. But I just wanted to put these up here because this is one of the tools, and this is the tool that's actually recommended by the CDC for diagnosing concussions, and there's various iterations of this form. This is the acute concussion evaluation. There's an emergency department version, there's a primary care version, and then there's a school nurse version, which I think is really cool, which is really helpful if someone at a primary care doctor's office or a school nurse kind of fills out this form and sends the patient with them, sends it with the patient. And as you see, it talks kind of a little bit about the physical symptoms, the cognitive symptoms, and these are those two big buckets of symptoms that we're going to see initially with any sort of head injury. And then after head injury has occurred, weeks later, that's when you start seeing more of the other types of symptoms, days to weeks later, the sleep symptoms and the emotional symptoms as well. And as you see, I wanted to highlight this big box right here, the red flags for acute emergency management. This is the kind of stuff that we talked about with the danger signs of any sort of head injury, right? So headaches that are worsening, seizures, any focal neurologic signs, repeated vomiting, slurred speech, weakness, numbness, increasing irritability or confusion, and then changes in the states of consciousness, right? So if a primary care doctor's office evaluated a head injury, they're like, oops, you got one of these, you got to go to the ER, and hopefully they'll send them with one of these forms. Similarly, this is kind of like a checklist that school nurses will kind of go over as well. Okay, what can we do in the field for any sort of head injury? Pain control, I think, is a huge thing, and I want to please give these kids Zofran if they're vomiting. You're not going to hide anything, okay? You're not going to mask anything. If there's one thing anyone can take away is give them Zofran. We want them to be comfortable, right? If someone's having a heart attack, we're still going to give them nitro, right? We want to make their pain go away. So give them Zofran. Hypertonic saline is the big thing that's now being done in emergency rooms and in trauma centers across the country for head injury. I like hypertonic saline. We've seen some great results with it. I don't know whether it's ready for prime time in the field just yet. It doesn't have very many bad consequences, but honestly, there's only been one huge study done on hypertonic saline. I think there's a little bit more data that needs to be shown. And then I just wanted to quickly put this up there. These are the criteria that we use in the emergency room to determine whether someone needs to get head imaging. We do not routinely image head injuries unless there's something blatantly obvious, like they're persistently vomiting or their GCS is not 15 and it's been some time. That's when we really start thinking about imaging these kiddos. And we have two different types of criteria that we use. The PCARN criteria, which is a big pediatric emergency care research network that does all these studies on millions of children and then comes up with these criteria that say, okay, these kids are the high-risk ones that we need to image. The one thing that I kind of wanted to point out to you here is in kiddos under 2, whether they have a palpable skull fracture, and kiddos over 2, whether they have signs of a basilar skull fracture, so that's the raccoon eyes, battle sign, hemotympanum, that kind of stuff. We would think about imaging those. And then the types of severe mechanisms. So they have these cute little pictures down here. So rollovers, if there's any sort of auto versus, bicyclist or pedestrian with no helmet, a fall greater than 5 feet for those greater than 2 or greater than 3 feet for those less than 2, and ejection from a vehicle. So these are the kinds of cases that we think about imaging. The other ones we can observe them. So our job as pediatric emergency doctors is to save kiddos from radiation if we can. Okay, so really quickly about what risk factors lead to prolonged concussion symptoms. I know almost all of us, from the emergency room nursing standpoint to the EMS providers, we won't see this part of it. This is kind of where the primary care doctor will take over and the neurologist will take over, is what risk factors lead to prolonged concussion symptoms. So concussion symptoms are symptoms that can linger from a few hours to up to 8 weeks usually. Okay, on average. So a third of patients will experience concussion symptoms a month after injury. 1 in 10 are going to have these symptoms 3 months after their injury. And 5% are still going to have these symptoms a year after their injury. So it really kind of depends on their mechanism and some of these risk factors that the CDC has identified. And this is older children and adolescents, whether they've had prior head injuries, lower socioeconomic status, Hispanic ethnicity, how bad their initial head injury was. If they had a clinically important or clinically relevant TBI, those people will probably have more severe concussion type symptoms. And then anyone with a prior learning cognitive disability or neuropsych diagnosis. So those with seizures, those with depression, those with ADHD, those are the people that are going to have more severe symptoms and more prolonged symptoms. There are always going to be that time. I think this is very useful for the nurses and for you guys if anyone refuses transport on what to tell parents to kind of prepare for, okay? Yes, concussion can happen with any sort of head injury, but what are you going to do about it, okay? We're going to slowly return them back to their normal activity, okay? So that first thing we say is mental rest and cognitive rest and physical rest, right? So we want to make sure that we kind of cut out all the crazy sports that they're doing, cut out the TV time, cut out the phone time, easy, simple things that they need to be doing for short periods of time, good, healthy amounts of sleep, including naps during the day if they need it, and then slowly get them back to school, okay? A half a day at first or a few hours, or just the morning, and then a half a day, and then, back to school. And their pediatrician can work with the school counselor. There's a whole bunch of schools that now have this kind of back to school after any sort of head injury program where they have longer testing periods, things like that to kind of help them if they're still having symptoms of concussion. So it's something that we can always educate parents on to look into and something their pediatrician can help coordinate with their school. And then the other big question that everyone always asks is when can they go back to sports? And it's really when they're feeling asymptomatic when they're playing that sport. First, they have to feel asymptomatic all the time, and then they can try lighter versions of that sport, and then they can kind of go on. And this is kind of the steps that they list. Regular non-sports, light aerobic, sports-specific, and then they can go to full contact sports, and then full contact practice, and then back to the sport. Okay. I think that's all I have for you guys. Most of everything is from the CDC. You can go online. Everything is up there. Okay.